Thank you also to SEMO Behavioral Health for helping to make tonight possible, and also for making it possible for everyone here to receive free Narcan. Thank you also to our vendors and all of our speakers. And a special thank you to Amber Elliott for all the time and hard work she put in to organize tonight. Right down here, Amber Elliott. So we're here tonight. Drug overdoses, you may be aware, are currently the leading cause of unintentional injury in the United States. This isn't just a big city problem happening to other people somewhere else. It's happening here. St. Francis County has the 4th highest rate of overdose in the state of Missouri. So that's the doom and gloom. But though we're in difficult times now, tonight is about hope. So we're coming together as a community to offer hope. For those struggling with addiction, hope for recovery. For St. Francis County, hope that together we can save lives. I've lived in a lot of places over the years, and what I can say about this community, about St. Francis County, is that as a community, we care. We want to help one another. So our wish tonight is to bring awareness to what is being done and what more we can do to move things forward together. So we're going to be hearing from speakers tonight on various topics. Also, there will be time set aside at the end of the evening after all the speakers have presented for questions from the audience. And how that will work is we'll have a microphone that'll travel through the audience and people can just raise their hands and we'll get to you to ask your questions. We also appreciate your feedback. So you should have received an evaluation form on that check-in front table. We just ask that at the end of the evening, if you would fill that out and leave it in the box on the St. Francis County Health Center table there at the entryway. So our first speaker tonight is Ryan Lawyer. Special Agent Ryan Lawyer is a native of Missouri and is currently assigned to the DEA St. Louis Division as the Demand Reduction Coordinator. He was previously a member of the Missouri State Water Patrol. He holds a bachelor degree in criminal justice and an associate degree in law enforcement. After graduation from the DEA Academy in 2004, Lawyer was assigned to a general enforcement group, the Financial Investigations Group, and the St. Louis Airport Task Force, where he conducted complex narcotics investigations. Lawyer shares his unique expertise about drug trends and emerging threats with community coalitions, civic leaders, state, local, and national drug prevention organizations, as well as other federal agencies to support collaborative drug prevention and education efforts. So welcome, Special Agent Ryan Lawyer.
I forgot to tell you I'm a walker. Well, thank you all for being here tonight. Kind of what I'm going to talk about is, mainly how we got to where we are with the heroin epidemic. When I started doing my job now as a demand reduction coordinator about a little over a year ago, I thought, well, how am I going to do this? I was always the agent that, out doing what you would think an agent would be doing, tracking down bad guys, doing surveillance all the time, going out in the middle of the night, doing wiretaps, all these kind of things. When I got this assignment, I kind of had to look and do a little research. And I'm all about kind of layman's terms. I always say, I'm not the smartest person. I'm like the knuckle dragging, cop for the most part. So once I kind of started doing some research, it kind of made me develop some different thinkings about heroin. Most people don't understand where heroin comes from for the most part. Those slides that was up there just a second ago, that's a poppy. Most people understand that, heroin comes from that plant, but they don't understand that all the prescription pain pills that we see out there today come from the same plant. So that makes them the same thing. And what I'm going to kind of talk mainly about is these the opiate pain pills. Any type of the narcotic pain pills that you see out there today, that's why we have such a problem with heroin. I'll get into that here in a little bit. Right now in America, prescription drug abuse is more rampant than all other drugs combined. And think about that. What I always say, it's kind of interesting because if someone's going to take meth or coke or something like that, they have to make a decision. They have to say, I am going to take that meth or coke. It's not that way with the opioids. You can barely see it down there, but at the bottom it says perception. That's the reason we have a problem today with pain pills. It's perception. Everyone thinks, well, it came from a doctor. It's good for you. They would never take heroin because they know it's bad for them. It's kind of a trap. I'm kind of going to get into that in a minute, that how people accidentally get hooked into doing heroin. Go ahead. Okay, this slide here says 80% of the world's supply of opiates is used in America. I'll get to that a little more in a second. What people don't realize, and this is one of the big shocks to me when I started doing demand reduction work, is 80% of heroin users never intended to use heroin. So think about that. 80% of people who are addicted to heroin never wanted to use heroin. They get tricked into it. I always kind of compare, a lot of comparisons to cigarettes. You can't smoke a cigarette if you didn't want to, right? You can't smoke weed if you didn't want to. You have to make that decision. I am going to smoke this cigarette. Well, what happens is someone is in a car wreck. They blow out their knee playing football or volleyball or whatever it may be, and they go to the doctor and they get a 30-day supply of pills. They start taking those pills, and before they know it, they're addicted to them. They can, at that point, they can go back to doctors, say they still have pain, or they can, stop taking them. The problem is once they stop taking them, the withdrawals set in. And the withdrawals from opiates is absolutely excruciating. I always tell everyone, I'm addicted to caffeine. So what happens to me when I don't have caffeine? I get a headache, right? And it's kind of interesting when I think about things a lot different now. If I, have a caffeine headache, I can take an ibuprofen or a Tylenol, and about an hour it'll kick in, that headache will go away. But if I take maybe 1 or 2 drinks of Mountain Dew or coffee, it's gone within a minute. So that's how much my body needs that. It gives me a headache to say, hey, drink some caffeine. When you have these withdrawals from opiates, the withdrawals are absolutely excruciating. I'll be talking to someone who's, an addict, and I'll say, or a former addict, and I'll say, hey, what's the withdrawals like? And the first thing that happens is the blood drains from their face. They get white as a ghost because they're scared. Just thinking about those withdrawals scares them to death. And I say, no, tell me what it's like. It'll help me explain to others. And they always say the same thing. They say it's like that flu we get every year. That 24-hour flu that's ridiculously violent. But it's gone in 24 hours. They say it's like that times 10. I don't even see how that can be times 10. I don't even think it could be times 2 because it feels like it's going to wipe me out every time. Then they say it lasts for 7 to 10 days. So think about that. You got those type of withdrawals, and all you have to do is take one more pill and they're gone immediately. And that's where people start getting addicted and they switch to heroin. Those pills, once they can't get anymore, they're about $80 a piece. Who can afford that? I get mad at my wife for going and buying Starbucks every day. That's $5 a day. I say, man, that's $25 a week you're spending on coffee. So imagine how quickly that adds up when you are abusing those pills. So that's when people go down the street and they get a $10 bag of heroin. So go ahead. And a lot of it is just how we are as Americans. This slide kind of pokes fun at us as Americans. It's all about medication. By the time we're born, by the time we go on the ground, we're taking some type of medication because it's kind of the easy way out, right? What happens to us a lot is when we go to the doctor, when we're kids or we take our kids to the doctors always say the same thing. Take the prescription till it's gone. Because that's an antibiotic, right? We all know to take the whole bottle. What happens is that kid goes to, the doctor when they're 18, they get the wisdom teeth out, and the doctor gives them a 2-week supply of Percocet or hydrocodone or whatever it may be, and they take the whole bottle because they've always been told to take it till it's gone. Who in here's broke a leg or had a real bad injury? What'd you do down here? Broke your kneecap in half. All right, we'll take broken kneecap in half. It hurt really bad, right? How bad it hurt the second day? How about the third day? All right, you're a bad example. How about the 5th day? What about the 5th day? Did it still hurt? A little less? Bunch of pain pills. All right, you're a bad example. Basically, normally what people always say is, yeah, it hurt horribly for the first couple days. After the 3rd or 4th day, the pain was tolerable. What we'd say is once the pain starts to subside, stop taking the pills. You don't need 2 more weeks of pills once the pain starts to subside a little bit. So this is a circle of addiction. This is how the trap happens. Once you start taking those pills for whatever injury it might be, you start taking them over time. Once you stop taking them, the withdrawals start. You have to take more to keep from getting withdrawals, and before you know it, you're full-blown addicted. Go ahead. All right, this slide here always baffles me. The United States makes up 5% of the world's population, but we use almost the world's entire supply of these pain pills. I just don't understand that. Other countries have good health care. Granted, ours is the best in the world, but other countries have good health care. So there's a lot of theories behind why we use the world's entire supply, but I'll kind of leave that up to some of you. Go ahead. All right, let's talk about fentanyl. Everyone's heard of fentanyl, right? The heroin epidemic, or the opiate epidemic, it's kind of like the perfect storm. Back in the early 2000s, the perception of these pain pills was they're non-addictive. Doctors prescribed them heavily because the doctors were lied to, frankly, told that they were not addictive. So the doctor's like, great, I finally have a product to treat pain. A lot of people got addicted to them. They started using heroin. And then fentanyl came along. I have one slide that I show sometimes. It shows like the amount of deaths between like 2004 to 2014. It says they quadrupled. Well, they quadrupled because more people started using heroin because they were getting addicted to the pain pills. But then in 2015, everything changed. That's when fentanyl came on the scene. Fentanyl is one of the most deadly drugs on the planet. It's an opiate, but it doesn't come from the opiate or the poppy plant. It's synthetic. It's made in a laboratory. And now you can go ahead to the next one. And now Chinese cartels have figured out how to make it in laboratories, and they're making it by the ton. They're then selling that to drug cartels in Mexico, and it's coming across the southwest border by the ton. So think about that, by the ton. These are the lethal doses of heroin. So, it takes a little bit of heroin to kill you. Fentanyl, just a few grains of salt on your skin can kill you. That's how deadly it is. Fentanyl is used by states when they're administering lethal injection. So that's what all these states are using now to perform lethal injections, because it's such a deadly drug and very effective. 72,000 people is how many people died in America last year from drug overdose. Without Narcan, you could probably put another 0 on this, frankly. Luckily, we have Narcan to combat that a little bit. But this is Seahawks Stadium out in Seattle. It holds 72,000 people. So think about everybody in that stadium just dropping dead. How many people flew on a plane before? Yeah, were you scared? Always when I'm talking to kids, I'll be like, hey, were you guys scared to fly on a plane? They're like, no, I'm not scared of anything. I said, well, imagine if one plane crashed in America per day and killed everybody on board. Would you ever get on a plane? Then they kind of freak out. I would never fly again if that happened. Remember a year or two ago when those 2 planes went down in the world? A whole line of aircraft was grounded because everyone was so scared of some type of malfunction with that aircraft. So think about that. That's how many people die per day in America. You can't really see it very well, but it's like 192 people die daily. One of these large planes hold 172 people. So that's a pretty interesting statistic. Go ahead. So a lot of publicity out there about guns kill people. Well, actually, the statistics are that drug overdose is a leading cause of death among young people these days, more than traffic accidents and other things. Go ahead. All right, let's talk about fentanyl again. Like I said, it's a perfect storm. Fentanyl is one of the most deadly drugs we've ever seen, and it's coming into the area like crazy. I worked a case in 2005 in Oregon where this chemist down in Mexico, we arrested him, and he admitted to sending 2 kilos of fentanyl into the U.S. And everybody in DEA actually just freaked out. The people in Washington, D.C. are like, some guy in Mexico made 2 kilos of fentanyl. They were just like, holy cow, how is this possible? Now it's coming in by the ton every day. It's insane how much. You got to look at it from the drug trafficker's perspective. A kilo of fentanyl in China is $3,000. On the streets of America, it's $60,000. It's all about the dollars, right? All comes from China. Just because, here in America, it's really hard to get precursors to make it. In a lot of other countries, even in Mexico, it's hard to get the chemicals needed to make fentanyl. In China, you can get anything. So all that comes from China, and they're making it in factories. Now, the strange thing about it, we have agents in China, but we don't have arrest powers. We advise. So luckily, China just a few months ago made fentanyl illegal. So now, hopefully, the Chinese government will actually go down the street and shut down the fentanyl factory. The thing that really scares me personally as a DEA agent, we see this different, kind of the trends. This is what scares me. These are fake hydrocodons. They're fentanyl pills, for lack of a better word. You got to think about this, like, once again, from a drug trafficker's perspective. They have consultants. They understand that overdose is bad for business. So how do they mitigate the drug overdose? Because the last thing they really want to do is kill their customer. So what they do is they get some fentanyl. They start putting it in their own pills. That way they can control the dose. They don't got to rely on the guy on the street corner in his basement with a 7th grade education mixing this up and hoping he gets the mixture right. So I don't know if you can get that slide to work, but this is what's called a pill press. You can go on Amazon, buy one for $2,000, or you can buy a really cheap one for a couple $100. Get on the internet, then order you some fentanyl. You can buy anything off the internet. You'd be amazed. Every FedEx, UPS truck going up and down the road, it's got some kind of drugs on it someone bought over the internet. Trust me, every day, you would be able to find something on one of those trucks, unbeknownst to the drivers or anybody at UPS or FedEx. That's just kind of how it is. Even the U.S. Postal Service is, heavily used to traffic narcotics. So that's what we're seeing a lot of these days is people are buying buying fentanyl, and they will just start making their own pills. It's really scary because Xanax. Everyone's heard of Xanax, right? Xanax is everywhere. Every high school kid in America has heard of Xanax. Every middle school kid in America has heard of Xanax. To them, it's like, take one of these, it'll just kind of chill you out a little bit. It's heavily abused among those young kids. What we're seeing now is a lot of fentanyl pills that look just like a Xanax. You wouldn't be able to tell the difference between the two. So your high school kid takes one of those, they might just drop dead. An interesting news article that a news station in Phoenix, Arizona put out about a year ago. If you guys have time, Google, Phoenix Fire Department fentanyl overdose. And it's a story about this guy who was a captain for the fire department. He was like a major in the Army. He goes back for drill one weekend. He'd hurt his hand a couple weeks before, and he was awaiting surgery, so the doctor gave him some pain pills. And he gets to drill, and he forgot his pain pills. So he's like, oh, man, I forgot my hydrocodone or whatever. One of the guys says, well, here, I have some. And he looks at it, and it looks identical to what he's been taking. He takes it, and the next day they find him on the floor dead. Well, that was a counterfeit oxycodone or hydrocodone, and it was a fentanyl pill, and it killed him. So, like I said, now we're seeing it like crazy. These are some of the seizures that we've had recently in Missouri, Illinois, and Kansas. This was 60 pounds of fentanyl. It's enough to kill every man, woman, and child in the states of South Dakota, Nebraska, Illinois, Kansas, and Missouri, and half of Illinois. So think about it. 60 pounds we caught out on the interstate can basically wipe out 4 states. This was an interesting seizure down at Cape Girardeau. This is a tackle box filled with different types of pills. It's exactly what this guy was doing. He was ordering different types of drugs from China, putting them in his pill press, and making them, using the U.S. Postal Service to deliver them. So that's that's one of the scary things today. Like I said, these pills, we can make them look any shape, any design, any numbers, any letters on them. So you never know what you're getting. Kids, they don't really pay attention anyway. They say, take the blue one, it'll make you feel funny. Especially if it's something they've seen before. Oh, well, mom takes these. The only way out of this is through education. I always kind of compare it to cigarettes because, we all kind of understand how things were with cigarettes over the last 50 years. Back in the 60s and 70s, everybody smoked, right? Because everyone's perception was they were safe. Then it took decades to educate the public of the dangers of smoking. My daughter's 15, my son is 12. When my son was, let's say, about 6 or 7, I would have to tell him, you can't walk up to people in the Walmart parking lot who you see smoking a cigarette and tell them they're going to die. I know that they probably appreciate you being concerned for them, but you just can't walk up and tell them you're going to die smoking a cigarette. But that's kids' perception these days. So it's going to take all of us to educate the public again about the dangers of these pain pills and how to use them responsibly. So that way, when we're 18, we get our wisdom teeth out, we take 3 days worth of pills and not 2 weeks worth of pills and become addicted to them. Well, thank you all for being here. Go back and tell your friends and family kind of if hopefully you learned something about the dangers of these pills, because that's the only way we'll find our way out of this situation. Thank you.
So up next we have Amanda Fitzwater. Amanda was born and raised in Poplar Bluff, Missouri. She attended Central Methodist University and received her Bachelor's of Science in Psychology. She's currently working at Butler County Health Department as a prevention specialist for HIV and STDs and an HIV medical as an HIV medical case manager.
Hey guys, my name is Amanda Fitzwater, and I am the prevention specialist for 20 counties, and St. Francis is one of those counties. So I want to talk to you about harm reduction. This is something we all need to learn and implement in our lives. So the definition for harm reduction is a public health strategy that was developed initially for adults with substance abuse problems for whom abstinence was not feasible. Harm reduction approaches have been effective in reducing morbidity and mortality in these adult populations. So harm reduction has been successfully applied to sexual health education in an attempt to reduce both pregnancies and sexually transmitted diseases, including HIV. So as a harm reduction practice, we need to learn to be sensitive to people and not call names or be judgmental, because that's what is making them less able to come talk to us. So we don't want to use words describing them as junkies or misusers, because that makes them feel bad and they feel like they can't come to us for help. So we should always use proper terminology when talking to people, okay? Next, please. So I love this picture right here, because addiction does not discriminate. Anyone can become addicted to something. And so this is what we all need to pay attention to. It could be your grandma or your mom or your kid. So it does not discriminate. It takes that one time of them taking something and misusing it. So I want to talk to you about Narcan. So I know they're giving out Narcan after here, so I just wanted to talk to you about it. This is what Narcan looks like. It's small. And it takes just one little press and you could save someone's life. I mean, that easy. You just press it and insert into the nose and it's that easy. Narcan is a powerful thing, and if you have the chance to save someone's life with it, it's fantastic. So in this next one, it can be as easy as this by saving someone's life. Just this little thing right here. Next, please. I do want to tell you some of the signs and symptoms of an overdose. So you'll see the pupil here is small. It's like a pin. Shallow breathing, choking or gurgling sounds, pale or blue, cold skin. So if you come across someone like that, you definitely should be cautious. Also, the good thing with Narcan is that say you think someone is overdosing and you hit them with Narcan and it's not an opioid overdose, it's not going to affect them or hurt them in any way, okay? So here are some things that we should do if you come across an overdose. Call for 911 and give a dose of Narcan. Then you want to administer rescue breaths. Stay with the person. Sometimes it might take a second dose of Narcan, especially when fentanyl or something's involved. I've heard from our drug task force that sometimes they've had to give like 4 or 5 different hits of Narcan, and it still didn't help. So in this next one, I'm going to show you how to use the Narcan. So today when you get your Narcan, and if you ever have to use it, you know how to. So you're just going to peel that back, see this little thing here, and like I said, it's just this is what Narcan is. It's nothing scary. It's easy to use. And then you just press, and it administers the spray. That spray is what's going to help them come out of their overdose, okay? So after they come out, after the overdose, there could be some other side effects. Sometimes they can be angry, get violent, they could vomit and be combative, because this is sending them into a withdrawal. So this is taking that high away from them, and they don't want that. So next, this is Narcan. If you want training on how to use Narcan, or you have a facility, I know when we went and did our training, we did it through the Mo Hope and More project. So I wanted to give you this information so you had it at your fingertips. They were willing to come to you, or if you want to reach out to someone close by and get trained, it's very easy. The other one is the More. Okay. Next. So I want to talk to you about safe syringe programs. We don't have any near here, and I think they're very important. Everybody gets nervous when they talk about syringe programs and us giving needles to people. But the important part is we're keeping those dirty needles that could be infectious in some ways, like with HIV or hepatitis C, out of our parks, out of just anywhere. Because I know in Poplar Bluff, you can walk down the street and you're seeing needles laying everywhere. And we don't want our children, our grandchildren, our family members to come into contact. And so that's why I think giving clean syringes to people who use drugs is very important, because then we're taking in those bad needles that could be infectious to people, and we're taking them off the streets. It also helps give us that rapport with the client where we could potentially get them into treatment one day and help them get off the drugs. I want to show you a few harm reduction toolkits. So you can take sharp containers. They give out cookers for people to cook their drugs, because a lot of times they'll use spoons and they'll share those spoons with the water and drugs in them, and they'll just inject it. There could be blood in there, and then that's where it's being transmitted. So we're offering different ways to be safe. I know a lot of people dislike that idea, but like I said, if we can make it safer for them, and it makes it safer for our community too. I wanted to tell you about this. I don't know if everybody remembers in Illinois, Scott County, there was that HIV epidemic, and it was huge. 142 cases, and it was all linked to IV drug use. They were all sharing their equipment and needles, and this is how the outbreak started. So this is why syringe programs are so important, because on this last slide that I have, the CDC said that Missouri has 13 counties in Missouri that are risk for an outbreak like what happened in Illinois. And out of those 13 counties, St. Francis is one of them. So this is why it's so important. I do prevention, like I said, for 20 counties, and I have at least 5 or 6 of those counties under my prevention. It's important to keep our communities safe. And this should be a huge testament that the CDC is saying this could happen to your area if you're not careful. So taking these measures and being safe and cautious is important. So if you're not up for syringe access, doing other things in place could make it better. So I'm all done.
Judge Joseph Goff Jr. was appointed Associate Circuit Judge for St. Francis County by Governor Jay Nixon in 2015. Following his appointment, he was elected in 2016 and 2018. He is currently serving a 4-year term that expires in 2022. Prior to his appointment, he was an assistant prosecuting attorney in the St. Francis County Prosecutor's Office. He also served as an assistant attorney general for the Missouri Attorney General's Office in Jefferson City, and as an associate at Reeves and Goff PC in Farmington, Missouri. Judge Goff received his college degree from Southeast Missouri State University and his law degree from St. Louis University. He is a 2004 graduate of Farmington High School.
Thank you all, and I want to apologize as probably being the third most qualified person on that panel over there to talk about the law because we have from the DEA agent lawyer, and then we also have Robert over there who was a co-author on the bill. He's going to talk to you later. I don't want to steal any of his thunder, but he and I had a really interesting talk about the Good Samaritan Law before I came up here to talk about this. So I might steal some of what he gave me in that presentation. The first part to talk about is going to be section 2. I didn't skip a slide, nor did Amber mess up in changing the slide. Section 2 of this bill that was went into effect, as you saw, August of 2017, is where you see what you would consider the meat of the law. In that section, it says what actually the Good Samaritan 911 law does. And I'm going to call it the Good Samaritan 911 law, or I'm going to try, because we also have a Good Samaritan law, which I was confused about when I looked this up. There's a Good Samaritan law that says if you're a medical professional and you provide aid to somebody who needs it on the street, you may or may not be held liable for some of that legal stuff that could come out of that situation. So this is the Good Samaritan 911 law. It was intended, and I believe if you read section 2 behind me, you will see, to protect folks from criminal prosecution who call 911 because of a medical emergency or a drug or alcohol overdose. So what does it protect from and how does it protect you? But if you read the law there, I highlighted or I bolded the most important parts, but we're talking about people who seek or obtain medical assistance for someone who's experiencing drug or alcohol overdose. But then we also have the person who is the subject of the request for emergency assistance, medical assistance, that is the person who is overdosing themselves. And I take it, if we were to ask Robert, there are specific instances that cover each one of these scenarios, both the person calling for help, and the person who is receiving the medical assistance in the past having been charged with crimes. Now, as we go on in the slideshow here, it says you shall not be arrested, charged, prosecuted, or convicted for the following. So it's not every crime, and I feel like that's important here to talk about because it's not all crimes, it's not distribution, it is not endangering the welfare of a child, it is possession of a controlled substance, possession of drug paraphernalia, and possession of an imitation controlled substance. There's also public nuisance, and then we have some alcohol sections on there as well. Sale of alcohol to a minor, minor with the fake ID. I don't think I have music on my slides, did I? The interesting thing when I look this up is obviously we are here at the Opioid Consortium to talk about drug abuse, overdoses, and prevention of overdose deaths. However, when I was looking up the 911 drug law, it was interesting to me because we have several college towns here in the state of Missouri, and their focus in their newspapers was on the alcohol overdose and medical emergencies that arise out of alcohol abuse. So obviously that was covered, and I'm sure Robert, when he co-authored this, was thinking of those college towns where you do hear about those instances where somebody overdoses or drinks too much alcohol, especially college students in the atmosphere. At the bottom, there's two important things. There's violating a restraining order and violating probation or parole. Those are two very big things. And if you look at this list of what we are saying, someone shall not be arrested, prosecuted, charged, convicted, what you think about is removing the fear in that moment when someone starts to overdose, when two friends are together, or when somebody recognizes a person who is going into overdose. I believe the environment was such at the time before this bill went into effect, that the fear of prosecution, the fear of the legal repercussions of calling for help was greater than the need to save the life, or than the concern for the person who was overdosing. And it was in those instances, in that moment of fear, where you had that fight or flight. And in that instance, it was call help or run, and a lot of people chose run. There were several anecdotes that I looked at, people that went to Jeff City and testified. This was Senate Bill 501 that was passed. And one of them was a lady whose son had been unconscious in his friend's basement for 17 hours before anybody called for any help. And the other one was a lady who, I believe it was her daughter, who was unconscious for 20 hours in a car by herself before anybody called help. Now, whether or not that was kind of the psychology of somebody's going to call help, I'm not going to call because I see a person in that car that seems to be having trouble. But I think what this bill covers is specifically those instances where the friend or the person who knows this person just did drugs, I did drugs with them, we have drugs here, I can't call 911 because I'm going to get in trouble. that's the instance where the Good Samaritan 911 law is attempting to remove perhaps that stigma of, if we call 911, we're going to be arrested. Now, it does not protect from all legal repercussions, and that's what we see on the next page. Outstanding warrants under mules. There's a law in Missouri that requires law enforcement to run a mules check when they have a stop. When crafting this law, I'm sure they were aware of the situation, which is to say if law enforcement has a contact with a person, they have to run that person through the NCIC or the mules system to see if they have a warrant. It also doesn't protect you from being charged with any other offense. So we had those inclusive offenses on there. That's all that this law protects from. That's all that you have immunity from prosecution from. It also, and this is in kind of in the legal part, the protection of prosecution under this section shall not be grounds for suppression of evidence or dismissal on charges unrelated to the section. And that gets into some legal back and forth that you would see in court. But in reading these parts, what I see, and what I ran this by Robert, so he blessed all of this before I came up here to talk. But Robert told me, this is what I said, I think in looking at the 911 law, it is a shield for those that in good faith are attempting to get medical help for a person who is overdosing and needs it. It is not a sword. It is not something, and the example I used was if two people are using and they're afraid they're going to get in trouble, you can't go drag somebody into the room and then call 911 and be free from prosecution. That would be the sword use of this law, and that's not what it's intended. And as we get into the definitions, which is on the next slide here, talking about drug or alcohol overdose. Now we're getting back to Section 1. Section 1's definitions, which is why I skipped it. I wanted to get you all with the exciting stuff first. Judging by your reaction, I might have messed up on my ordering of the slides here. But they specifically defined a drug or alcohol overdose. And the reason is, as I said, they want to cover the situation. And if you remember from Section 2, it's a good faith request. And that good faith request is what you're going to look at if it was a judge, if it was a prosecutor, a law enforcement officer, as to whether or not this person was legitimately seeking medical attention for somebody who was suffering an overdose, or if this was perhaps not a good faith situation where simply the person was attempting to evade prosecution for what was otherwise a crime. They define drug or alcohol overdose specifically, and we can go through all of these, but essentially it covers what we just talked about with the Narcan. When you're going to need to, it's recognizing somebody's overdosing, those symptoms are covered in here such that if you call for help 911, it is not something that you're going to be prosecuted for any of those listed crimes. Again, like I said, it's not all crimes, it's the listed crimes. On the next slide, we talk about medical assistance. And this includes reporting a drug or alcohol overdose, being the one who calls 911, assisting someone who is reporting, or providing care to someone who is experiencing a drug or alcohol overdose or other medical emergency. Now, the other medical emergency I think is pertinent here. However, it maybe is not something that is as relevant for this discussion tonight. I think it's important to talk about, though, because they weren't focusing solely on the drug abuse or the alcohol abuse, but this is any medical emergency. And as I said, I think the intention is in the moment to remove that initial fear when somebody realizes a situation is going bad, that they can call 911 without necessarily worrying about those legal repercussions that you would have from any of those laws. And those are substantial, because I know in terms of probation or violating parole, those are very serious considerations for an individual. And I believe when the legislator passed this law, I don't know this for a fact, but they were looking at increasing the value of human life over necessarily legal consequences. And balancing that act, you have to look at that. And so to tell you how this law is going to affect the courts in Missouri, prosecution in Missouri, criminal justice in our state, I can't tell you, but the law is always a balancing act. And so in order to maybe speak a little bit about commentary in terms of how this law affects our lives, I would say looking to any court, to any prosecutor, agent lawyer, or people that just call themselves lawyers around here, it is always about that balancing act of the good faith request for help. Now, there is a wide berth in there, and in the state as it's being implemented now, I can't necessarily say for sure how it's going to be enforced, or even reassure people as to how it would be enforced if in a particular situation, if somebody in here right now tonight calls 911 for help because somebody may be experiencing a drug overdose, it's a different situation that's going to be interpreted differently. However, thanks to Robert and the folks that drafted this bill, they drafted it specifically enough that I feel like they can give the reassurance to individuals who may be in a position to call 911 when somebody is experiencing a drug overdose, to not worry necessarily about the consequences immediately, but to focus on the human life. So we don't have the teenager in a basement for 17 hours or the young lady in a car for 20 hours who is experiencing an overdose and is well beyond any help. Because again, as we just heard, Narcan is an incredibly simple drug to administer, and it's incredibly effective. The longer we wait, the more we try to worry about covering up what's happened, the further away we are getting, or we are pushing that person from their possibility of holding on to their life in those moments. The last section of this law is one that I've not had a lot of familiarity with. I read it, it's in the law. I don't necessarily know, and I can't really speak to how it is being forced, but I think it's relevant in talking tonight, as Agent Lawyer talked about, the importance, and I think as we see this as a country dealing with opioid abuse and overdose, education is going to be critical. And empowering in this law enforcement, the ones who perhaps at one point, folks who would be in a situation to call 911 would be afraid to see, would be afraid to have them come up. Now, possibly we can make them ambassadors of drug help, because as a population, that's who they're going to interact with most, is law enforcement. And empowering law enforcement, maybe taking away the stigma of sharing information for drug help, is going to go along with that education that's going to be necessary if we truly are going to have any hope in terms of actually understanding opioid overdoses and getting help to the people that need it. And as I said, and as Robert and I talked about before, we may all have had come to our mind a situation where we think of 911, and we may be thinking of that dark cellar or that lonely car in the middle of the night in the Walmart parking lot where people are using. However, those aren't necessarily the folks that encompass 192 overdose deaths a day in the United States. Those statistics are made up of two teenagers who, one of them whom has a legitimate prescription for an opioid, and they give it to their friend and their friend starts having trouble, or who get into their mom's medicine cabinet, and because in that moment they're afraid to call 911 because all they know is they maybe did something bad and they might get in trouble. Those are the lives that we're losing as well. It's not maybe your worst case scenario, the stereotypical in your mind, what you're thinking of, an overdose and somebody in a dark, forgotten cellar who their family hasn't checked in on in years. These are people, these are children that all of us have and that all of us care about in the community that are losing their lives to overdose. And I think, and as Robert will say, this bill was passed in a lot of ways out of frustration, out of those critical moments that were lost when someone was sitting there pondering the legal consequences of calling 911 instead of just calling 911 and getting the individual the help they needed. It's a very brief overview of the law. I apologize for not going in depth on it. As I said, it's 2 years old. It's a balancing act when it comes to the courts and how these are being interpreted and how this law is being applied. However, I do believe already it's made a difference, and I hope as we move further along, as people become more familiar with this, we do see more 911 calls immediately, and we do see more folks who would have otherwise been left for dead brought back, or at least having the opportunity to be administered the Narcan that is so vital to these overdose situations. Thank you all very much.
Up next, we have Dr. Scott Kirk Lee. Dr. Kirk Lee was born and raised in Poplar Bluff, Missouri. He attended Southeast Missouri State University in Cape Girardeau for his undergraduate degree. He attended medical school and residency in internal medicine at University of Missouri in Columbia. Dr. Kirk Lee is licensed and board certified in internal medicine. He has been employed with BJC Medical Group at Parkland Health Center since 2007.
Hi, I'm so honored to be here tonight. My position, I think, on this panel is to provide some education about what we can currently do for those people who are currently dealing with addiction as a main part of their disease. Next slide. So, and I think as we started off tonight, we got some idea about what opioids are. In essence, opioids are a broad group of pain-relieving drugs. They work on a very specific receptor in the brain. It's called the mu receptor, and it's synthesized from the poppy plant, or synthesized in a lab, as already mentioned. I have at the bottom kind of a list of some of the more common ones we've seen, and many of them have been mentioned already tonight, but the one at the end of this is one that commonly gets overseen, and that tramadol itself is an opioid, but it's a very common drug that people use. This, I think, is probably one of those slides that I've given about 12 talks about opioids, addiction and management, and how to start a clinic and how to treat people over the last 6 months. And so every time I see this slide, I think about leaving it out because I feel like I've talked about it so much that everybody already knows this. But this is one of the more common things that I think people misunderstand about addiction itself. We tend to group all forms of opioid use into this general category of addiction. And as I point out here, addiction is a very complex condition. It is a brain disease. It's manifested by compulsive actions that, despite harmful consequences, people tend to repeat. It's driven usually by people who, once they've taken an opiate, they get a sense of euphoria. And if you've talked to people who have this certain kind of brain chemistry, and it's estimated that about 5% of the population has this, the sensations they get from using an opiate cannot be mimicked by anything else they've ever experienced. It's better than sex, it's better than winning the lottery, it's better than anything we could possibly imagine. The parts that have already been hit on too, the bottom one is the dependence. This is what we were talking about, where somebody uses a medication. Once they've used the medication, they try to stop it and they withdraw. They have symptoms of withdrawal, which then makes them dependent on the drug to stop those symptoms. And as already mentioned, that does drive people to switch from using prescription drugs, which they're no longer going to be prescribed because doctors are getting better at cutting off people who have been on pain medication, who don't need to continue long-term pain medication, as well as people who are buying it off the streets but finding cheaper versions and the more toxic stuff that's currently being laced, like heroin, and fentanyl is, I agree, a very nasty drug all around. And then the other one, I'm sorry, go back one more. The tolerance, and this is the part that people don't see a lot. These are the people that are taking pain medication with or without a proper explanation for it, who after a certain time, the pain medication doesn't relieve the pain the same way. Or if they are getting the euphoria from it, they're no longer getting the same euphoric feelings, and so they have to start upping the amount. This is dangerous, and some of the categories where we see somebody who has, say, been an opiate user who goes to prison or is removed from that in some other way, and for a certain amount of time, they're no longer exposed. They had a very high tolerance when they went in or when they were removed from it. When they come back and they start using again, they think, well, the last time I shot this much heroin, and the first time they do it, they overdose and they die because their tolerance is no longer there. Next slide. I think, as we've kind of already talked about, intervention for this can be very successful. It involves education, it involves harm reduction, but I think that as we work through this, the big part is kind of changing the perception of what we're dealing with. And we have to start understanding addiction as a disease, not as a just personal choice that's meant to ruin somebody's life. I tell people all the time, very few people wake up one day and they think, I wonder what the quickest way to ruin my life is. Heroin? Let's try that. Nobody really does that. So if we start looking at this as a disease, it's a little easier to kind of pull back how we feel personally about it and start treating it. Because I've never been upset when somebody with high blood pressure or diabetes comes in and told me they ate chocolate cake or salt. Next slide. Oh, wow, that's really small. Okay, the nice thing is that the only part of this that I think is really important, no, I'm just kidding. When we're treating addiction, this is usually a multifactorial kind of thing, and I think, again, we're trying to see that theme tonight. Counseling is absolutely necessary for people that are dealing with addiction as a disease. Most people lack coping skills. It's just that most people don't tend to cope by using drugs. And so anybody who's dealt with addiction as a disease, when they tend to run into problems, and sometimes not even problems, when good things happen, they don't know how to cope with them, they tend to turn back to the thing they've always enjoyed or the thing that's always helped remove the psychological or physical pain they're dealing with. So counseling has to be part of this because people have to learn to cope. The second part of this, the medical assisted therapy, I will get into in just a minute. And then the last part is a community program called Communities That Care. A lot of these kinds of programs are popping up everywhere. There are links to this if anybody ever wants to see this. If anybody asked for this presentation, you can absolutely have it. On the very bottom of this was a New York Times opioid crisis solutions, where they asked a bunch of people who are deeply in the opioid crisis. They asked DEA agents, and they asked doctors, and they asked social workers, and they asked community leaders. If they were given a certain amount of money to combat this, where would you spend your money? It's fascinating to see where people would spend the money. As doctors, we tend to think that all the money should be put into medication. And there's actually good reason for that. Not that the other stuff, again, doesn't matter. But there is good reason for that. Next slide. So this is the big part of what I do, medical assisted therapy. It's commonly known as MAT. That's how it tends to be referred to. And there are several medications that we tend to use for this. The one that is the old tried and true is methadone. Methadone is a synthetic opioid that was developed. It is extremely powerful. When methadone clinics came about, and still are actually, I guess, they're very highly regulated. Methadone is very addictive, and it was primarily used to treat people who were heroin addicts who had developed a very high tolerance to opioids. They just didn't find something strong enough to be able to treat those people. They would withdraw on the other opioids, so they started making methadone and using it at high enough doses to be able to treat the withdrawal for people. Methadone clinics still exist. They, again, are very highly regulated, meaning most people that are in a methadone clinic have to come and get their methadone on a daily basis. They literally have to show up to the clinic every single day to get their dosing. After a certain amount of time, they are allowed a grace period where they can go home with a, quote, take-home amount, which is usually about a month's worth of the methadone. But that usually involves at least a year or two of them being very stable in the methadone clinic. Suboxone and Subutex is where I primarily work. Naltrexone is akin to Narcan. I don't know if anybody's ever seen or heard of this, but naltrexone has been primarily studied in alcohol addiction. It seems to be very, very good with this, but studies have actually suggested that long-term long-term opiate relapse rates are the same with naltrexone as it is with Suboxone. And then clonidine is one that we are seeing more often, but it's used to treat more addiction or more acute withdrawal in patients as opposed to long-term therapy. Next slide. Oh, I did talk about some of this. Naltrexone, like I said, is something it works like Narcan. It blocks the euphoric effects, and it is not displaced by other opioids. If you have it on board, you can't get high on it. But it does seem to affect the cravings that people tend to have for this. Next slide. All right, that's really small too. Okay, let me see if I can kind of sum up here. So Suboxone or Subutex, the drugs have been around actually for about 20 years. Suboxone itself is actually generic at this point. As an opioid, Suboxone is unique. The drug name itself is buprenorphine. Buprenorphine has a very high affinity for the opioid receptor, meaning that when you take buprenorphine, if you have other narcotics in your system, it will absolutely displace them all. It will come in and it will kick them out. And some of the problems that you see, or some of the, I won't say the problems actually, because I'm not sure if it's ever been proven, but some of the risk with buprenorphine is that if somebody has recently used and they take buprenorphine, that you could put them instantly into withdrawal because it's not actually as stimulating at the receptor as a lot of the other narcotics are. Because of its affinity for the receptor, though, if you are taking buprenorphine and you try to use other opiates, you actually cannot get high off of it. It also has a very slow dissociation rate from the receptor, meaning that once you've taken it, it sits there forever. So it does its job for a very long period of time. With my patients that I work with this kind of medication, most of them will take the buprenorphine several times a day. And more of that's a psychological effect of wanting to take something more often because that's usually how they were taking the opiates before. But because this has more than a 24-hour life to it, technically, as long as the dose is small enough, you can take it once a day. Buprenorphine also has what we call a ceiling effect, meaning that when you take the medication, you can't, if you try to overdose on it, the drug does not become effective at doses higher than 24 milligrams a day. You can't overdose on it. It doesn't cause the respiratory suppression because it doesn't stimulate the receptors that a lot of the opiates as strongly as the other opiates do. And while I'm not an addiction specialist, and I've talked to more than a few people that have prescribed Suboxone, there is some disagreement about this. I am pretty sure you cannot kill yourself with Suboxone. Next slide. Currently, every physician in the United States that holds an active DEA license and all mid-level providers, nurse practitioners, and physician's assistants are eligible to get the waiver to prescribe Suboxone. I appreciate the fact that they allow people the opportunity to go and get education for this. But since you can't kill people with Suboxone, I think that the waiver program should absolutely go away, and anybody with an active DEA license should be able to prescribe. As part of the presentations that I give, I typically talk about some of the history of opioids and what we call scheduling of opioids. So when drugs in the United States are classified, they're classified into one of 5 classes. Schedule I drugs are drugs that have been deemed to have no medical value. So heroin, methamphetamine, technically cocaine is in there, but is a level 1 narcotic, or is a Schedule I drug. Schedule II drugs are the really, really powerful ones that you have to be very concerned about. These are the oxycodones and the stronger opioids, including hydrocodone, which is more common. Schedule IIIs are things like Tylenol 3, but this is where Suboxone fits in. It's actually a Schedule III drug. Schedule IVs are non-narcotic drugs that are controlled like Lyrica, and Schedule Vs are basically blood pressure medicines. Next slide. So my experience for this has been, the last 3.5 years I've been prescribing Suboxone, and there are a few things that I kind of take away from this, and I try to encourage people to think about. Now, I will tell you that I give this presentation to other providers in hopes of inspiring them and encouraging them to go out and get a waiver and start treating addiction because it's such a need. But I think that this kind of applies for everybody. You know, I think that we've already hit on this, and that, you know, we can't really treat people as addicts. We can't label them. We don't label the diseases. We don't tend to be so down on every other disease that affects people's lives the way that we are down on people that are suffering with addiction. And while I know this is primarily about opiates, I would say that any addiction probably deserves that same common courtesy as a human being. Personally, it took me years to get here. When I first started my program, everybody had 6 months to get through it. They would come in, I would put them on Suboxone, and I would titrate their Suboxone down within 6 months. That was the rule. And I'm pretty sure nobody completed that program. And then after I realized that people were just using drugs again and I was not helping them, I said, okay, well, maybe it shouldn't be 6 months, but everybody has to get off Suboxone. And nobody completed that program either. And at this point, I think that my treatment of patients is that they have a tendency to get to control how we treat their addiction. I don't come in and tell them what we're doing. I ask them how they're doing. I ensure that they're working with counselors. I ensure they're doing what they should be doing. But the big part of this is number 5. And it's like, it's really not about you. It has to be about them, and it has to be there all the time. Next slide. There has been some of this thought about how to really kind of fight this. I believe that, you know, doctors are getting the idea that they're prescribing too many narcotics, and they've kind of stopped doing that. The federal government is getting some really stupid ideas, like just flat out saying you have to produce 50% less narcotics, and that pharmacies will now have caps on how many narcotics they can give out per month. I believe these things are really, really irresponsible, and as has already been touched on, those people will start using heroin. It is very cheap, and it is very available to everybody. So we need to be careful about how we do this. But some of the more, or some of the better thinkers about this have developed some of this stuff. Number 3 has already been talked about, right? This is something that everybody should be walking around with. If you know somebody who owns a narcotic, who takes a narcotic, whether it's as needed or it's all the time, there should be Narcan. They should go together. I think that number 2 has been pointed out as well. You know, we need to aggressively treat people who go to prison. A lot of people in prison have problems with opiates, and they need to be treated not just when they get out, but during their stint in prison to help control the addiction so they have a better chance when they get out to maintain that sobriety. Drug checking services. Nobody's touched on this yet, but the concept that you could take your illegal drugs and walk into a police station and have somebody actually check this for fentanyl before you take it and die is way outside the box, but would absolutely result in harm reduction if we could convince people that we will in some way decriminalize a lot of what we're seeing here. Drug take-back programs. A lot of people have a lot of opioids sitting around they just simply don't need, and those drugs typically find a way to find somebody who will be willing to use them. Drug monitoring programs. Number 7 is something that Missouri is the only state in the entire United States that does not have a prescription drug monitoring program, except for St. Louis County decided to just start their own because the state wouldn't. It is growing, and it now covers about 85% of all Missourians, but it allows doctors to actually get online and see what somebody's been prescribed as a narcotic. So if I'm sitting there and somebody says, I need this for my pain, and I believe the pain is something that would require a narcotic, I can get online and look to see if they've actually been prescribed. Are they doctor shopping? Are they pharmacy shopping? What are they filling and when are they filling? I would hope that at the times when those things are identified, people will not treat them again as addicts, but try to encourage them to treat the addiction itself as a disease, engage them in what they're missing. Drug use centers. This is something that gained some popularity in Canada. This is the idea that you could come to a place and shoot your heroin where there are medical professionals sitting around with Narcan simply to bring you back without arresting you. And then I'm like number 4, but I know that people know that that's probably the hardest one ever to get rid of. So next slide. Oh, great. My time is done. Thank you all. Again, I'm gonna leave here with 2 Narcan if I can, just so everybody knows. I think everybody should.
Our next speaker is Robert Riley II. Mr. Riley was released from incarceration in federal prison in May of 2008. After years of substance misuse and incarceration, he was able to sustain sobriety by seeking help through a 12-step program. In 2012, Robert met Chad Sabora while detoxing a heroin user at her home. They went on to form the STL Heroin Help, a nonprofit aimed at providing resources to heroin users. Robert and Chad have gone on to form the Missouri Network for Opiate Reform and Recovery, another nonprofit organization that provides education in local high schools, legislative advocacy, and other community involvement battling the opiate epidemic. Robert has been labeled a recovery activist by addiction counselors throughout Missouri and continues to be a part of the solution to the opiate epidemic gripping the country. Robert and Chad wrote and advocated passage of all of the naloxone distribution laws for the state of Missouri. They have gone on to write and successfully advocate for 911 Good Samaritan legislation and several other pieces of important criminal justice reform legislation. Robert is credentialed as a certified reciprocal alcohol and drug counselor and is employed as an addiction counselor at Clayton Behavioral. He owns and operates 5 recovery supportive houses in St. Louis.
Talked about everything already. My name's Robert, and I'm a person in long-term recovery. And what that means to me is I haven't found it necessary to use drugs or alcohol since September 6th of 2006. And for that, I'm extremely grateful. I'm not from Missouri. I was born and raised in Orange County, California. I was raised by a single mom. My father went to prison when I was 2.5. He's a heroin user. My dad's currently 71 years old, released from incarceration. He hasn't been back, but he's living homeless currently in Las Vegas, Nevada, actively using drugs. And that's okay. That's his choice. I've offered him options. He's refused them. I still love him. I was in Vegas about a month ago. Mark Zuckerberg from Facebook invited 50 recovery advocates from across the country to do this thing called Mobilize Recovery. And I was invited, and while I was there, I got to have lunch with my dad, and it was a great day. It was sad to see him, but it was great to see him like that, but it was great to see my dad and be able to buy him lunch. My mom is never really, I was telling somebody earlier, my mom's like a 2 glass of wine a year type drinker, and she usually gets drunk off that first glass because she's like 5 foot tall. You know, no substance use issues. I was raised, she was, you know, it was just her and I for a long time. She raised me with good morals, good upbringing, taught me right from wrong, beat me when I needed it. No, I'm just kidding. She did, though. And my mom struggled with mental health throughout her life. You know, she sought help, got help. I found drugs and alcohol when I was 14. And I'm not going to go through my whole life story because I want to touch on some of what's going on in Missouri and tell you what I'm doing today, because this is about hope, right? That's what you told me? All right. So my story is this. I drank whiskey for the first time when I was 14. Within 1 week's time, I had smoked some weed, I had done some cocaine, and I was on my way to Compton, California to buy some PCP with some older guys. Drugs made me feel good. Why do people use drugs and alcohol? Because they work. That's why they use them, because they work. Drugs and alcohol were never my problem. Drugs and alcohol were my solution. The problem is that I was using a high-risk solution that caused me incarceration, the loss of friends, the loss of relationships, the loss of family, for my mom to cry herself to sleep every night I was incarcerated and the nights she didn't know where I was. And that's a high-risk solution. And it took me a long time to figure that out. I was released, you heard me say my sobriety date is September 6th of 2006. I was released May 14th, 2008, and that's when I came to St. Louis because my mom lives in the St. Louis region, and that's where the feds put me. And I had 20 months of sobriety. And that came about because of 3 things that happened in August of 2006. One is my little cousin was shot and murdered over a drug deal. He was 21 years old. He thought I was the best thing. I thought he was the best thing. But he was living that lifestyle, and it cost him his life, and he was a great kid. The second thing that happened was I received a letter from my son, Aaron Riley, and it started out, "Dear Robert, stop writing us, stop calling us, stop saying you're our dad. Dads are there for birthdays and hockey games, and you've never been there for any of that stuff. So we just don't want to hear from you anymore." And the third thing that happened is I was walking the track with this old school cat on this federal penitentiary, and I was telling him about my dad. I was telling him about my little cousin. I was telling him about me. I was telling him about this letter from my son. And he said, "Come out here tomorrow, I want to show you something." And I came out the next day, and he handed me a piece of paper, and it was his time computation sheet. And next to release date, it said, "Deceased." He said, "Check it out. If you don't change everything right now, this is what you're going to end up with." See, in the feds, a life sentence, it's called truth in sentencing. It's a life sentence. If you get 50 years in the feds, you're about to go do about 48 and a half of them. It's not like the state system. And those had a profound impact on me. So I came to St. Louis. Literally, the only thing I owned were the clothes that my mom mailed down to the federal prison I was in. Rode the bus up here, did 6 months in the federal halfway house, stayed sober, got a job at a printing company, met a girl who was going to be a social worker. She started writing papers about my life. I wanted to know what the hell she was writing about me. We started talking. She said, "Maybe you should go to college." I applied for a scholarship for this organization that gives scholarships to people in recovery. I went to college. I got a job at Clayton Behavioral. I met Chad Sabora. We started helping people who were using drugs. We started handing out naloxone on the streets of St. Louis in 2012. Everybody said, you're enabling. We said, the only thing we're enabling is breathing. And then Chad, my best friend, who you mentioned, is a former prosecuting attorney who became a heroin user. That's how we wrote the laws. And so we wrote the 9/11 Good Samaritan Law. It took us 6 years to get it passed. But in the meantime, we wrote the naloxone laws that we now have in the state of Missouri, and we got those passed. I went to Steve Stinger, the former St. Louis County executive, who I knew his nephew had died of an accidental drug poisoning. He got the prescription drug monitoring program started for us, and now we have about 78% of the state covered. We do run a needle exchange program in St. Louis with the blessing of the mayor, the city prosecutor, Kim Gardner, and the chief of police, because it does reduce, it's a public health crisis that we have. It does save lives. It's not, listen, we all practice harm reduction, right? How many of you drove here tonight, right? How many of you wore your seatbelt? Harm reduction, right? When we passed the seatbelt laws, it didn't make people start doing 150 down the highway, right? No, it was just to keep you safe. Should you decide to do over 100 miles an hour, right? Or experience an accidental drug poisoning, because they are accidental. Very few overdoses are on purpose. That kid that lied in that basement his mother is a dear friend of mine. That's why we wrote the 9/11, because we didn't want to have to talk to another mother. I'm a harm reductionist. I practice harm reduction. I've been to the White House 3 times. I stood behind the governor when he signed the naloxone laws into law. I was with the governor the day he signed, former Governor Greitens. Why do we have so many former politicians here? Former Governor Greitens when he signed SB 501, which also made it against the law for judges to tell people they had to go off their medications. A lot of judges around the state were doing that, telling them you couldn't be on Suboxone, you couldn't be on this, you couldn't be on that. And today, I own 5 sober houses. I just opened up a brand new world-class treatment facility not too far from here in Dittmer, Missouri, called Sauna Lake Recovery Center. I interviewed a psychiatrist this morning for a job. By the way, did I tell you guys I have 14 felony convictions? I'm considered a violent offender. The director of the Department of Mental Health gave me a recommendation letter last week so I could adopt my little sister-in-law. My wife lost her mother about 3 weeks ago, and I was actually able to get it, but I can't vote. But I can do all these things. There's hope. Is there any hope yet? Is there any hope? I'm a convicted felon. I got a job. Don't tell me you can't go get a job if you have felonies. I own my own company. I have 70 people working out at Sauna Lake for me right now. Don't tell me you can't do anything. Who was it that asked me earlier, said, what happened? And I said, the pastor. And I said, I took some actions and my life changed. That's what I did. And I plugged into the recovery community. So we can shame and stigmatize, and we can keep showing people locked up and walking away in handcuffs, and we can talk about the parents that overdose with the baby in the back seat, or we can start humanizing this. These are people that are suffering, and they're part of our community. And I've spoken in this community. I've spoke at the local high school, not this one, but I spoke at other local high schools and junior highs and at the college up here. And I have the same message. Like, my story is great. I'm the exception in a lot of ways, but not more than the mother who is pregnant, used drugs until she gave birth, had to go through the court system to get that child back that was born addicted to drugs, got the child back, and never used drugs again. Her story is far more powerful than mine. My son, my oldest son, not the one that wrote the letter, but my older son, works for me at Sauna Lake. We do recover. I get to come out here and talk with a DEA agent, public health worker, a judge, a doctor, and another person that works in this field with me. How blessed am I? I do recover. Thanks for letting me share.
Our final speaker is Mark Wardlow. Mark is a licensed professional counselor, certified co-occurring disorder professional diplomat, and a medication-assisted recovery specialist. He has more than 10 years of experience working with individuals suffering with substance use and other mental health disorders. Mark is currently serving as the Chief Clinical Officer with Southeast Missouri Behavioral Health.
My name is Mark, and I work for SEMO Behavioral Health, as it's known commonly everywhere. I'd just like to say that I am very happy to be the last speaker of the evening because I don't have to say a lot because they covered it all for me already. What I wanted to talk a little bit about, though, was SEMO, and we've learned all of this information of what the opioid use that's going on in our local area is, and so I just wanted to talk about what can we do about it. And so we are the recipient of many state and federal grants that can help individuals get care like the counseling, medication-assisted treatment at little to no cost. So if an individual doesn't have insurance, that's not a problem. I don't want that to be a barrier for anybody that's seeking help. Of all of the substances that detox really exists for, you have alcohol use disorders, benzodiazepine use, and then opioid use. Detox is available for everybody, regardless of their ability to pay. So if you have a loved one that has an opioid use disorder and they've been using it chronically and want to get help, all they have to do is show up. So if they walk into our location that's out on 32 Highway, 55, 36, 32 Highway, and they have that opioid use problem, and they come in there and they say, hey, I'm here for help, they're going to get it. A lot of people kind of give SEMO a little bit of a bad rap, saying, there's more drugs in there than there is out on the streets. That's something that I've heard. Or as soon as they get out of there, they just go and they relapse again. So what good is that program if that's all that happens? And so I just wanted to just dispel a couple of the myths as it relates to that. Do people overdose or relapse after they leave treatment? Yes, that does happen. But it's kind of like I would say suicide is. When an individual has suicidal ideation or attempts, did you know that after they get out of the hospital for being treated for that they're at a higher risk of suicide than before they went in? See, I don't think a lot of people understand that to be the case, but it is a statistic and it is a fact. And why that is because when an individual goes, it's the same thing for substance use. When an individual goes in for treatment, there's a lot of things that they're given. They're given supportive system. They're given housing that they may not have had before they came in. They're giving food, shelter, social connectivity. They're making friends, getting counseling. When they go to turn around and leave treatment, they don't necessarily have all those things again when they go and they leave. So those coping strategies that they've learned, they try their best to use those. They may or may not be effective because a lot of times they get overwhelmed by all of those things that they don't have again. And so like Dr. Kirk Lee said, their tolerance level may have been way up here when they came into treatment. It's now way down here. They turn around, they get overwhelmed, they don't have the ability to use those coping strategies, and they use that same amount and they overdose. So that's kind of what happens, and it is a little bit of a cycle, just like with suicide. When they go into a hospital and get treated for that, what you send them there to the hospital for to get help for, they're actually at a higher risk, and it's because the treatment centers and the psychiatric units, they can't fix all of those problems that aren't going on right then and there. They can try, and that's why it's very important for continued use, for outpatient care. And this is a disease, like Dr. Kirk Lee made it a point, and I advocate for it greatly, that substance use is a disease. It's a lifelong condition. It's not going away. There's not a cure. There's not a magic pill you can take and all of a sudden you're healed. It's a lifelong condition like diabetes, like high blood pressure. So treatment for it needs to continue, and it needs to be time unlimited. And then we go to the other myth now, where they're talking about SEMO has more drugs inside there than exists out on the street. And are there drugs in any treatment center? I would say that I can bet you that no treatment center is without substances being brought in. And there's a very important reason why. Like, I'm sure he can speak on incarceration. Are there drugs in maximum security prisons? Yes, and those are highly secured areas. Do you think the substance use treatment center is more secured than that? I don't think so, and especially since there's laws that exist that don't allow us as a state-funded facility to actually physically touch a person when we're searching their belongings and searching their items. So to say that substances can't get in, it does get in. Now, we have lots of policies and procedures around how we search and what we do to try to reduce the risk of that happening, but there's no way that we can be free of it if even a maximum security prison can't be. So I just wanted to dispel those myths. Again, talk to you guys just a little bit about SEMO. We offer counseling, connection to medication-assisted treatment. We work with Dr. Kirk Lee's office quite frequently. We get individuals help when they need it, and again, at little to no cost. And if you do want help for you or your loved one, please just stop by. Say you're there for help, and you're going to get something. Nobody walks away with anything. We're one of the only treatment centers in the state that offers services for everybody, regardless of even if we accept you into our program because of maybe limited funding or maybe because of some other reason that we just aren't able to help. You're going to get group education. Anybody can come and attend groups. We're going to try to determine what funding you may be eligible for. If an individual has eligibility for Medicaid or other state-funded insurances, we're going to help you apply and get that. So that way your door opens to a lot more help in the state. We're going to do something. If you walk in asking for help, you're just not going to get nothing. And so that's really what I wanted to stress and what I wanted to say. And I don't really have a whole lot else to say, but I wanted to thank you guys for coming out here tonight.
Since addiction is being recognized as a disease and no other disease that I know of is treated as a criminal offense, do you guys see laws changing to protect people who suffer from addiction rather than being punished for it?
I was mainly talking about the laws as they are right now. I certainly am not a legislator. We may have a legislator in the audience, but I can't necessarily forecast where laws are going in the future. I do think, as Robert described to me before, and as we've heard from all the folks on this panel, what I do see is an increase in the understanding of addiction. Now, whether or not that manifests fully in our criminal code, I can't speak to that. And the laws as they are right now, the state of the laws as they are right now is the state of the laws. But there are people like Robert that I think are working in a progressive manner to bring about that understanding, perhaps at the governmental level, that could potentially affect some of those changes. Robert, do you want to add to that answer?
Hello, thank you all for attending, even the people in the audiences. I guess my question is primarily for Dr. Scott Kirk Lee, if that's how you pronounce it. I hope I didn't butcher it too bad. I really appreciate you spending your education and your life, trying to help others with medically assisted treatment. Which I'm a fan of. I mean, I think that's the only approach to get people off of it. What is your take on the 3 to 5 day detox and then out the door? Do you ever see, let me follow up with that, do you ever see a 3 to 5 day treatment followed up by a shot of Vivitrol? Because a lot of times they're kicked back out on the street. We were talking earlier up there about cigarettes and coffee. If you take someone off of cigarettes for 3 to 5 days, or off of coffee or nicotine or caffeine for 3 to 5 days, first thing they're going to do, if they're not completely committed to getting off of that, if they're going to go out and have a cigarette, probably 2, or they're going to go out and have a cup of coffee, maybe chase it with a Mountain Dew. And the same thing is happening on the 3 to 5 day detox. All the heroin, the opiates are out of the system. That's about how long it takes to clean up. Am I about right? Is it 3 to 5 days, and most of the opiates are out of your system?
The like measurable amount in the system,
Right.
yes, but
So-
withdrawal itself may take longer than that.
Right,
if you're not treating it.
So my question to you, to the entire panel, do you ever see a day where the 3 to 5 day detox is followed by either mandatory Vivitrol or a treatment center? Because the 3 to 5 day detox is killing people, in my estimation. I mean, that's the way I feel. I mean,
Can I ask one question?
Sure.
When you say 3 to 5 day detox, what is that treatment that you're referring to? Is this just
hospital
cold turkey, watch
yes,
them withdrawal?
Yes. The police officer will find someone on the street, or someone will overdose in a house. They go to detox in a hospital somewhere, in a hospital setting. They detox, let's say 3 to 5 days or 7 days, and they're out. Hopefully you have someplace that they can land, that they can be treated. Heroin is a lot stronger, obviously, than nicotine or caffeine.
Yeah.
So
I mean, theoretically, naltrexone actually shouldn't be given to anybody who's used opiates within 10 days. So the idea of letting somebody withdraw and then giving them naltrexone, you may, even if it's been 3 to 5 days, you may, if they're even coming out of it, you may actually induce worsening withdrawal by giving them a Vivitrol shot. If you're asking my personal opinion on this, and I'm going to try to do the best I can to kind of put my spin on this, too often Suboxone, because it's classified as an opiate, and it is an opiate, it works on the opiate receptor.
correct.
Too often we see it as, the most common word I hear is a crutch, right? People believe this is trading one addiction for the other. That actually can't be further from the truth. People that use Suboxone, what it does generally is it makes them feel more normal before they use drugs before. Since you can't get high on it, and since it doesn't induce the euphoria associated with opiate use, it's not addictive, right? Now, again, I've talked to people who would argue with me all day whether or not it's addictive or not. Addiction, like I said, is seeking the drug despite negative consequences. The negative consequences for Suboxone are probably along the lines of constipation, and that's about it.
Right.
It doesn't lead to death. So allowing, and to address a program that would allow somebody to detox in a way where you just simply watch them suffer, I'm not sure who does that. I hope that there are a few programs that do that if they do that. But those people should absolutely be given Suboxone to treat that withdrawal. And I would equate this to the idea of, somebody had touched on this, and this is part of the education that I give to providers and to other people who like the science behind this, is I mentioned neonatal abstinence syndrome and the rates of neonatal abstinence syndrome. And this is the child born to a mother who's using opiates who comes out and the child withdraws. And the rates are high, right? And everybody who talks about this, you start to feel the lump in your throat because you think about these babies. We treat neonatal abstinence syndrome with opiates. So if people think it's okay to let people withdraw and watch them withdraw, would we allow that for a baby? Would we just sit there and watch a baby withdraw and hope that, if it needs to be intubated, we would intubate it? I mean, it's not a judgment or a question, but we have good tools now to treat withdrawal, and we should absolutely be doing it at every turn. Naltrexone's ability to help with withdrawal is none. It would induce withdrawal. But its ability to help with relapse is still being studied. The original studies say that long-term relapse rates are the same with naltrexone as they are with Suboxone. They're absolutely the same, whether you give it as a pill or a shot. It's about a 70% that they will stay sober with those medications. The problem, of course, is that most people, when they're having problems with opioids, they're withdrawing. They're not coming to me, they haven't used in 2 months and they're just looking for a drug because they're having cravings. That's pretty rare. And those people I do try on naltrexone. I do, right? Because naltrexone, even as safe as Suboxone is, naltrexone is even safer. So it's not necessarily that it doesn't have a place. But the place more likely in the future for where we're treating this is people on Suboxone who, after treatment for however many years or how long it takes, who want to come off Suboxone. And that's when I say want, I mean the patient decides whether or not they're going to come off. If they do, I would encourage all of them, once they're off Suboxone, to go on naltrexone. Okay, I would. And and to be honest, I've been doing this 3.5 years. I have 0 patients who have ever done that. 0. Nobody has ever come off Suboxone and gone on naltrexone in my program. But when you look at addiction as the disease and how long it's treated for, it is the same as everything else. The studies are saying that people need to be on Suboxone their entire lives.
Correct. Thank you. I appreciate that.
Sure.
That last comment was great.
Yeah. And one more to add here.
Yeah, and so over at Southeast Missouri Behavioral Health, we do have a 3 to 5 day detox program. And so I think it's important to understand what the purpose of the different levels of treatment are. A 3 to 5 day detox isn't intended to necessarily treat all of the underlying things that may exist for that individual who is using. It's really, its only purpose is safe monitoring through that initial period of what they consider to be the dangerous period. So with opioid use, you won't die from the withdrawal of opioid use. You're gonna feel like death, but you're not gonna actually die from that. Now, for alcohol use and benzodiazepine use, the withdrawal from that can kill you. And so the most dangerous time period, for example, with somebody who's using alcohol, for example, is the point right before and at they get to not having any more alcohol in their system. So the purpose of detoxification is to safely monitor that individual during that most dangerous time, and that's really all.
And again,
I would say too, I'm sorry, if I misconstrued that, because if it's more of a watch them for a certain number of days, not everybody who comes off opiates withdraws, right? So when we're talking about withdrawal and not to correct, but people actually do die from opiate withdrawal. Opiate and alcohol are the 2 big withdrawals that actually do kill people. But when they do withdrawal, if they're in severe withdrawal, there's no way that people should be holding them in a clinic or any facility that doesn't have the ability to treat withdrawal. Those people should be treated. If they're in severe withdrawal, if they're sitting there vomiting their guts up, looking like death, diarrhea and stomach pain out of the world, those people need to be treated. Now,
Absolutely.
If people are just coming and going, look, I last used heroin 12 hours ago. I'm not sure if I'm going to have withdrawal, and we're going to monitor, and they may get a little agitated. They may feel a little cramping. That's not what I'm talking about. I'm not saying every person needs to be instantly put on Suboxone. What I'm saying, though, is that the levels of withdrawal need to be evaluated, and I'm sure anybody that's doing a detox program, they would recognize the ones that need to be sent to the hospital, because that stuff is scary.
And my biggest concern is after that last day when they have detoxed completely and are let out the door, that they are given something to go home with. Thank you.
The something they could go home with as well is Suboxone, though. That's I think we need more use of that, honestly, more providers.
And I think it's important to know too, when Dr. Kirk Lee's talking about the elimination of the waiver to be able to prescribe Suboxone. Now, for emergency room physicians, they can prescribe a limited day supply, 3-day supply of Suboxone without being waiver trained.
And unfortunately, as we see in almost all communities, there are not nearly enough Suboxone prescribers. So after that 3 days, they're withdrawing again, and it's hard. It's very difficult right now.
First of all, I'm a recovering addict. I got 14 months clean, and I would like to see more help with Suboxone whenever you go to detox, because sometimes we just get clonidine or something like that, and that if a person ain't getting what they need to get treated in detox, they're more liable to leave. Like I had a friend that come out from the city and go to SEMO, which I'm not down in SEMO at all because I love SEMO. They saved my life, but he went to detox, and he couldn't get nothing for like no Suboxone or anything. They was just giving him clonidine so for the 3 to 5 days. So I would like to see, can we work on that?
I don't want to speak for SEMO, but I'm sure they would too. Yeah. That's the finding the resources, that's the limiting part of that.
And I just wanted to add to, like, speaking for SEMO, that is something that we are looking at trying to actively pursue, is that what can we do for everybody? The only problem is that, everybody's their own individual. And, as far as I'm not going to speak, on behalf of whatever physician that was, but when they evaluated that individual, they must have thought there was some reason why they did not want to go that route, because we definitely don't put any kind of limitations on any of the physicians that we use. So the fact that he did get a medication tells me that he did see a physician, and there must have been some other factor involved in that decision making. But we want to offer the most effective form of treatment and the most evidence-based practices for treating addiction, which is always a combination of medication and therapy.
Hi, I'm not sure if anyone here will be able to answer my question. I'm actually a social worker with 20 years experience in the mental health and substance use field, and I am the mother of a heroin addict. Been suffering with her addiction for 2 years, and just about 1 week ago, I know that she has a warrant, and she called me from a local drug dealer's house claiming that she was being held captive in the restroom. So I called the police on my daughter. Who does that? Hi. I told them that she has a warrant and I would like for her to be arrested. I met the police at a secure area, and in the meantime, as we were going to the house, she phoned again and said that she had fled, escaped, and was hiding in the bathroom of a local restaurant. So I followed the officers there. We located her in the bathroom, and it was very evident that she had a syringe sticking out of her jeans. Well, they couldn't frisk her because there was 2 male officers there, so they took her to the station and I followed them. And they came out with a syringe full of what appeared to be brown tar heroin. They simply released her straight onto the street with a warrant. I'm pretty sure I'd still be in jail if that were me. And, they offered no help whatsoever. So now I still wonder every day, where's my daughter? Is she alive? Because since that time, due to lack of help from the authorities, I have no idea where she is or if she's alive. Thank you. Speechless, huh? Thank you.
There you go. Well, on behalf of law enforcement, that does sound kind of strange. I don't know, there's a big difference between the federal government and then local law enforcement. And I don't know if maybe they were confused about the Good Samaritan Law or something, but obviously there's something that's probably, not really correct there. So I would think we all would be just about as, confused as you are. So I'm sorry I don't have a good answer, but that would be something that, and maybe they, what a lot of people are doing now when they get arrested, she didn't even bond out, it sounds like. So she wasn't even, So that's strange. Normally what'll happen is they'll go ahead and book the individual and then, release them pending charges. And then it's up for, the prosecutor to actually file charges. So, I'm kind of confused as well. So sorry I don't have a cut and dried answer.
We just, I think yesterday we found a senator, a state senator that's going to pre-file the bill in December for us. So hopefully this is our 4th year with a syringe access bill. So we'll see what happens. You know, last year we had the whole mess with the governor because it kind of shut down all the legislation right there at the end. And quite honestly, I mean, it's the state that we live in. Most of the overdoses and accidental overdoses and the high rates of HIV and things like that are in St. Louis metropolitan area, Kansas City, Springfield area. And so the legislature is represented by people from rural areas. I'll give you an example. A couple of years ago, we were at the hearing on the, we were having a hearing in front of committee for the syringe access bill. And the chairperson, we got up there and we presented all this data. We presented the Scott County, Indiana information. We presented, you know, how much their return on investment, hoping that they'd hear that on what's being spent on Hep C through Medicaid for the state by the state of Missouri. Presented all this data, and the chairperson's response was Pope Pius, I don't know, the 13th or something, was against it. And how are you going to beat a pope, right? But like that's what we get. That's what we're up against. Either deeply religious, rural representation, or just the conservative. You know, lock them up and throw away the key. It's just now that the state. You asked about decriminalization of certain things or alternative sentencing. It's just now that the state's looking at it. And why are they looking at it? Because of budget concerns, right? We can't build enough prisons. They ran out of money for the prisons. So now they're willing to start looking at restructuring the sentencing laws, getting rid of some mandatory minimums for nonviolent offenses and things like that. Listen, Europe does it the opposite that we do. They do treatment up front, and then if you don't successfully complete that, then they do punitive on the backside. Whereas we say, well, we can successfully treat 60% of the population with about $10,000 with treatment services. But no. See, we want to spend $44,000 to lock them up this year and then send them back out on the street suffering from the same substance use disorder. And then I'll just finish with this and I'll shut up. We were talking about the barriers. The FDA has deemed that buprenorphine is safer than Adderall, safer than Adderall, right? By the schedule of drug that it is, right? Any doctor can prescribe you 500 Percocets tonight. But in order for a doctor to prescribe buprenorphine, which is safer than Adderall that we give to 9, 10, 11-year-olds, this doctor has to go through 8 additional hours of training. Then he's only allowed 30 patients his first year. Like, we have all these barriers to people getting well, right? Here's what France did. France got rid of all barriers. They said, you don't even have to have an OUD diagnosis. Anybody can come in, any physician, anybody can prescribe it. You can give it to them right out of the office. Here's the buprenorphine. Within 3 years, their overdose death rates dropped by 79%. So if you guys want to do something for me, vote. Contact your state legislators. Contact your state senators. That's how we're going to get things changed. We're not a lobbyist. We're not lobbyists. We're 2 guys that rode up to Jefferson City in my old Ford Explorer, and we knocked on doors until we found somebody that had been affected by this. When we found a state, his name was Stephen Lynch. When Stephen Lynch, his best friend's son had died from an accidental overdose. When we found him, we started getting traction with some of this legislation. It's not because we wrote amazing bills. They weren't supported. but we found somebody that was emotionally attached to it and not just financially, right? We need just regular people to stand up and say, every third household in this country has been affected by addiction. We need people to start saying something about how we spend our dollars. If you can do anything for me, vote this year. Contact your state legislator. Tell them that we need some help. We don't have Medicaid expansion in this state. That's why everybody goes over there. That's why Illinois has a lower overdose death rate than we do. And our drug supply is poisoned here. The DEA agent talked about that. You can't even find heroin in St. Louis. I am almost like, when I see the bus in the paper of heroin, I'm almost like, let that through. They weren't dying like they are with the fentanyl. And the drug dealers aren't exactly working in a sterile environment when they're weighing up their dope. So that's why the people that are buying meth are accidentally overdosing because it's got fentanyl in it. The people that are buying cocaine, the weekend warriors, are accidentally overdosing. Right? That's what's going on in our area. Sorry to be a bad news guy.
Talk to her about the syringe program. So down here, we are definitely trying for a syringe program. We have talked to the Department of Health and Senior Services, and they said that we could do harm reduction. But if needles are exchanged in any way, they are to come out of like an outsourced pocket. So we are definitely trying to get something here. It's been a year now that we have just pushed and pushed and pushed. But like he was saying, you have to go and talk to your legislators because they're the ones that are going to push this bill through and make it where we can have something like this to help people.
If they hear from 5 constituents in each district, that's when they listen to us. 5. If just 5 of you from this district emailed tomorrow and said, I support syringe access programs because it saves lives, then when I go to Jefferson City at the first of the year, that one's actually gonna listen to me. That's what we need. It doesn't take much.
Amanda, I don't know if you said this earlier, but I wanted to mention on syringe access. Places that have syringe access programs actually have a higher rate of people in treatment and recovery as well. So it's coupled with the program of getting people into treatment and recovery resources as well. Now I'll go back to being the mic lady. Okay.
Hi, my name is Sherry Hampton, and I'm a program director for a newly formed program for diversion. Like you were just talking about, the feds have decided to start spending some money. We applied for it, and we got it, and we're trying to provide intensive services to substance abuse users who have lost their children, helping to expedite getting those children back. Unfortunately, there's so many people that have this need, and we have such limited amount of services. However, I have 2 questions for you. We do offer the MAT for that reason. In our program, we like to support that. But we are finding that the people that are in our program cannot sustain that cost once we can't help them pay for that. Do you see that ever becoming something that will be more affordable or that insurances will cover? And then my second part to that question, I'll just go ahead and ask it because you probably can answer it at that time too, is I know that medical marijuana is becoming something that is past here now. It's fixing to start happening. How do you think that that is going to affect the opioid issue?
I'm assuming that was for me. Okay. So Suboxone is generic. Once people realize how much money can be made by selling Suboxone through pharmacies, you'll see competition that will drive the price down. And so, yes, I do believe it will be affordable. I don't believe it'll be affordable like $4 prescription affordable, but I would say you will probably see cost ranges somewhere in the $30 to $60 a month at a standard 16 milligram dose within the next few years, would be my guess. I've not bought any stock in any company that makes Suboxone, but The second one about medical marijuana is, I think, very, very difficult. The studies around medical marijuana are not high quality studies. So the problem with studying medical marijuana, and I just, I know there's a very political opinion about medical marijuana and marijuana use in general. In general, as a doctor, I don't care about marijuana. It doesn't restrict access in my program. If people are positive, they're positive, and I don't care. But when people ask me if it's useful, because they read the story about some kid who had 500 seizures a day, who now only has 15 seizures a day because they're taking marijuana and they tried every other drug, I still say, do you think 15 seizures a day is a good thing? But it's almost impossible to study marijuana, because when we study drugs, what happens is we isolate the chemical, we measure it, and we put it into a milligram or a unit dosing. So we know how much we're giving people. That's not what's happening with marijuana. Marijuana is typically taken, and if it's smoked, there's no way to measure it all, number one. Secondly, if it's put into an edible, it's usually given as like a percentage of THC versus CBD, but it doesn't tell you how much of each of those is actually in there. And so it's hard to standardize whether or not it's useful on any level, because you don't know how much you're giving people. You could be completely underdosing, trying to figure out if it helps reduce pain, overdosing if you're trying to figure out if it helps with sleep, or anything in between for what other indication people think it's useful for. Personally, I think that it probably does have some uses, but when you see studies coming out now that say that medical marijuana does not actually decrease the amount of opiates people use for pain, they have me very concerned about this idea that it's some wonder drug that people think it is. It is probably neither the devil nor the angel people think it is. It probably works really well for a very small handful of people, and it works really poorly for a very small handful of people. And the other 95%, it's like drinking a glass of wine in your house. So I think that if you want to know more about medical marijuana, what they're going to have to do is they're going to have to figure out how to standardize it in a milligram so you can test it. Double-blind and placebo-controlled trials. It's a way to know, but we can't really do that now. Nor do I see anybody really working to figure this out, which makes me concerned that there's too much money in legalization for anybody to actually know the answer, right? We like to study drugs after there's no more money to be made, because then we find out a lot of drugs don't do stuff, But when there's money to be made, nobody really wants to know the answer. We just want to make money until then. So. Sorry, I think that is more of an opinion, but. It's okay. You might have anything else to add about medical marijuana?
We are really close to it. I'll take one more question, but they're trying to kick us out of here, so.
No pressure for the last question, by the way.
I know we've talked a lot about the adults and addiction, but I'd kind of like to know more what we're doing with kids. I feel like a lot of school districts aren't even doing the DARE program anymore, and I feel like the whole thing needs to be revamped. I lost my oldest daughter back in August. She fought with heroin addiction for 2 years. She was 4 days after her 21st birthday, and she was clean for 9 months before that. And I look at this child that taught herself 8 instruments, was going to go into the military, and I think these kids need a program that shows them that it can trick anybody, or ways to take pain medications when they have a knee injury in high school, football. They need to be educated in those ways, not just here's how you say no, here's a clever way to walk away from your friends who are trying to trick you into taking drugs. I feel like the whole thing needs revamped. And our children who are going to grow up into the adults who are going into these treatment programs could be educated in a more aggressive way, in a more real way, and a more, they need to realize it can be them. I guess I feel like kids already think they're invincible. That's just part of it. But they don't, I don't know what the answer is. And I know I was ignorant to it until it touched our lives. We've never dealt with it before. And so when I saw what it did to this child that I would have never, ever thought would have been able to have been tricked by this, I realized how much more we need to be doing in our schools and how much that needs to be changed. And I just wondered what you guys thought on that.
So I do prevention and I'm in 20 counties. But we recently have been doing a CQI project with Johns Hopkins University. And we actually started this year a program in Poplar Bluff called Smart Moves, Smart Choices. And we go in and we discuss misuse of prescription drugs, but we have revamped it a little bit to go over all different kinds of things. When I first went in to talk to these kids, they were teaching me things that I had never known. And so now we go in and we've shown a film called Written Off. I don't know if anyone's seen it. If you can, it is a story about a young man's journey with heroin. And it really speaks volumes to these kids. And then we go into the curriculum. So we teach them what is misuse of prescription drugs. A lot of these kids think, oh, if my friend gives me a pill, it's not bad. And so we're trying to change that view for these kids. We're seeing more kids, especially in Butler County. We've had several kids overdose and die with heroin. And so we want to get in there in the high schools and junior highs and middle schools and talk to these kids and make it relevant. A lot of parents might not like that, but we've noticed that these kids are really learning a lot when we do our pre-test and post-tests, and they're opening up to us. So we can talk to them about Narcan and tell them they have options. And then afterwards, you have these kids texting you on Facebook or messaging you and saying, how can I get trained? So I think once we have this program, now we can flourish it everywhere if possible, if school districts want it. That's the thing. The school has to want it. We can give them all the tools to implement it, but it would have to be the school district's decision to take it and run. I know that our school district has done it. This will be the second year, and it's went fantastic, and the kids have learned. And no, they do think they're invincible, and some of them don't think that they're going to learn anything, but at least getting in there and just showing them is a progress in my book with these kids, because they think they're invincible. So we are out there trying, and we are trying to move that education throughout Southeast Missouri. So we're trying for sure.
That's one of the primary things I do, is go into schools and talk to kids through all ages. Like I mentioned earlier, my son going up to the people in Walmart parking lot, I never told him anything about cigarettes. He got that at school, like in second grade, and developed that perception. But it is all about getting asked by the school. There are some schools that they just want to have this, we don't have a problem. And I always try to say, well, you might not have a problem now, but we're trying to give these kids something in their skill set when they're 20 years old, when they have that accident, or when they're exposed to that type of opioid. So you as parents, just like Robert was saying, as far as voting, you have to be the squeaky wheel. Call the school and ask, hey, I heard you guys aren't doing DARE anymore. Why not? Well, okay, hey, DEA will come to your school and put on programs for free. There's a lot of other organizations out there who'd be happy to come into the schools, but the school just have to ask for it. 8th grade health is the best. I'm pretty sure in Missouri, 8th graders are required by law to have a week of drug class. I always tell every school, I will come out and teach the class. And sometimes I'll be out there for 2 or 3 days in a row teaching health the whole entire time. And today we're talking about this drug. Tomorrow we'll talk about a different drug. So you have to ask for it. Beat up the schools. Sometimes the administration is always changing, and you have to be that squeaky wheel to make them, reach out to us.
And one of the other things to do, like that was mentioned earlier, is talk to your legislators. I mean, the laws are changing all the time. There's a hand in the audience because we have one of our state legislators. Now he's made himself known. Dale Wright, one of our state representatives here with us. We're happy to have him. But talk to them about it, because the laws are changing, and they've recently made suicide prevention a mandatory part of school policy, and having prevention programs in the schools. And for the St. Francis County, the resource is prevention consultants. So I would reach out to them and ask them too what they're doing in the schools, and they'll be able to provide you with a lot of information. Additionally, the youth treatment provider is Preferred Family Health Care, who treats for substance use in the ages of under 17 years old.
I just want to say our schools, I don't know if there's anybody from the school, but all of our schools are looking at this. It's something that we've been working with them on at the health department, and they've been involved with our opioid consortium. So they're looking at it and they're thinking about it, and they are wanting to make changes to the curriculums. They're also thinking a lot about vaping right now because that's a really big topic, which is a whole other thing. But just know that they are thinking about it and they are looking to make improvements. And I know that some of them are already on the steps to instituting evidence-based programs for that. That being said, we're always thinking about prevention. I think at the health department, we care about prevention deeply. And that's something that we're always asked about. But it should be known that some of those things are not as easy to nail down. When we talked with the CDC, when they came to St. Francis County, which is a really good thing and also is a really bad thing if the CDC comes to your county. We asked about prevention and kids and those types of things. And there's a lot of things that are going to be happening around adverse childhood events that put people at risk later in life to develop a lot of different things, but especially substance abuse disorders. So that's a harder thing to nail down, is how to address adverse childhood events. And I know that that's something that they're going to be working on, and at some point maybe something that we're working on as well. But that's something to note as well. It's not as easy as a thing, and there is no silver bullet for these things, or we'd be doing it. So.